Namaste, Bitya. Namaste, Pushpa. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In this series, we are discussing about the diseases of the locomotor system. In the past lectures, we have discussed about the various diseases like osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, and reactive arthritis. In today's lecture, we are going to discuss about another important disease, that is psoriatic arthritis. I believe that you must all have seen all those topics that we have covered from the book, and you must have revised all the topics because it is very important for you to go through the books in order to see for the various things. Now, let's start with today's topic. What is psoriatic arthritis? What is the etiopathogenesis, the clinical features, the investigations, and the management of the same? So, psoriatic arthritis. What is psoriatic arthritis? Psoriatic arthritis is a chronic inflammatory arthritis that affects around 5 to 40% of the patient or the persons with psoriasis. It refers to an inflammatory musculoskeletal disease that has both autoimmune and autoinflammatory features occurring in the individuals with psoriasis. It is usually seronegative and is often involved in the distal interphalangeal joints of the fingers and the spine and sacroiliac joint. It has the features similar to that of ankylosing spondylitis and reactive arthritis. So, psoriatic arthritis, it is basically a chronic inflammatory arthritis that affects 5 to 42% of the patient with psoriasis. It refers to an inflammatory mucosal disease that has both autoimmune and autoinflammatory features occurring in the individual with psoriasis. It is a seronegative disease and is often involved the distal interphalangeal joint, the joints of the fingers, and the spine and sacroiliac joint. It has features similar to that of ankylosing spondylosis and reactive arthritis. Now, how does the onset of psoriatic arthritis takes place? Onset of psoriasis usually precedes the development of joint disease. So whenever the joint disease are seen, psoriatic arthritis diseases are seen, you often see the onset of psoriasis that precedes the development of the joint disease. There are nail changes that are seen in 90% of the patients with psoriatic arthritis. There are 6 patterns of nail involvement that are seen. It includes number 1, pitting, number 2, horizontal, ridging, onycholysis, yellowish discoloration of the nails, margins, dystrophic hyperkeratosis, and combination of these findings. So, nail changes are seen in 90% of the patient with psoriatic arthritis. The onset of psoriasis precedes the development of joint disease, and there are 6 patterns of nail involvement, which includes pitting, horizontal ridging, onycholysis, yellowish discoloration of the nail margins, dystrophic hyperkeratosis, and a combination of these findings. So, clinical presentations of moderate to severe fingernail psoriasis. I have shown the pictures of all these presentations in my PPT that I have attached on the portal. So, you will be seeing the pitting, the leukonychia, the crumbling, the subungual hyperkeratosis, the onycholysis, and the splinter hemorrhages. So, I have shown by means of different pictures how the psoriatic nails look like. And after having psoriasis in the early part of the life, the patient develops usually psoriatic arthritis. Now, what are the different patterns of joint involvement that we are going to see in case of psoriatic arthritis? There are usually 5 patterns of joint involvement that are seen. Number first pattern is asymmetrical oligoarthritis. Here, it involves the distal interphalangeal, proximal interphalangeal joints of the hands and feet, the knees, wrist, ankles, and the sausage digits. The sausage digits that we have seen in case of reactive arthritis may be present, reflecting the tendon sheath inflammation. The second one is the symmetrical polyarthritis. So first one was asymmetrical oligoarthritis. Oligo means few joints, and asymmetrical involvement. It often involved asymmetrical oligoarthritis involved distal interphalangeal joints, proximal interphalangeal joints of the hands and feet, knees, wrist, ankles, with the sausage digits that were present, reflecting the tendon sheath inflammation. There are symmetrical polyarthritis that resembles rheumatoid arthritis, except rheumatoid factor that is negative in absence of rheumatoid nodules. The third variety is predominantly distal interphalangeal joint involvement. That is seen in 15% of the cases with a high frequency of association with psoriatic nail changes. The next variety is arthritis mutilans. Arthritis mutilans occurs in around 3 to 5% cases with the aggressive destructive form of arthritis with severe joint deformities and bony dissolutions. There is spondylitis or sacroiliitis with the axial involvement that is present in 20 to 40% of the patient with psoriatic arthritis. It may be absence of peripheral arthritis. So the first variety was asymmetrical oligoarthritis. Second variety is symmetrical polyarthritis. Third is predominantly distal interphalangeal joint involvement. Fourth is arthritis mutilans. Mutilans means destruction, excessive destruction of arthritis with a severe joint deformities. Next is spondylitis and sacroiliitis with the axial involvement that is present in 20 to 40% of the patient with psoriatic arthritis. It may be occur in absence of peripheral arthritis. Now, how to evaluate? I have shown you the pictures of arthritis mutilans, the different form of the severe form of destruction that you are going to see in case of psoriatic arthritis. Now, how to evaluate a case of psoriatic arthritis? Whenever a patient of psoriatic arthritis is coming to you, how will you evaluate the patient? You have to check for the negative test for rheumatoid factor, because we all know rheumatoid arthritis is also having a lot of destruction of the joints. So first of all, you have to check for negative test for rheumatoid factor. There is hypoproliferation of anemia, elevated ESR. We have hyperuricemia that may be present. The HIV infection should be suspected in fulminant diseases. There is inflammatory synovial fluid and biopsy without specific findings. The radiographic features will include erosion at the joint margin. There is bony ankylosis, tuft resorption of terminal phalanges. There is pencil and cup deformity with bone proliferation at the base of distal phalanx with tapering of the proximal phalanx. There is axial skeleton with asymmetrical sacroiliitis, asymmetrical non-marginal syndesmophytes. Now, let me repeat the evaluation. In the evaluation, you will have to check for the negative test for RA factor, rheumatoid factor, hypoproliferative anemia with elevated ESR, hyperuricemia may be present. HIV infection should be suspected in fulminant diseases. There is inflammatory synovial fluid and biopsy without specific findings. Radiographic features include erosion at the joint margins. There is bony ankylosis, tuft resorption of terminal phalanges with pencil and cup deformity, the bony proliferation at the base of distal phalanx with tapering of the proximal phalanx, axial skeleton with asymmetrical sacroiliitis and asymmetrical non-marginal syndesmophytes. Now, diagnosis. How to diagnose a case of psoriatic arthritis? When the patient of psoriatic arthritis is coming to us, how will you diagnose such case? Diagnosis based on the JASPER criteria. The patient must have inflammatory articular disease. So there must be presence of inflammatory articular disease, that is of joint, spine, or enthesial with greater than 3 points from any of the following 5 categories. The evidence of current psoriasis, a personal history of psoriasis is present, or the family history of psoriasis. There are typical psoriatic nail dystrophy observed on the current physical examination and the negative test for rheumatoid factor. So for diagnosis, that is known as JASPER criteria, patient must have inflammatory articular disease of the joint, spine, and enthesial with greater than 3 points from any of the following 5 categories. Number 1, evidence of current psoriasis, a personal history of psoriasis or a family history of psoriasis. So history of psoriasis must be present. Typical psoriatic nail dystrophy observed from the current physical examination, a negative test results of the rheumatoid factor. Either current dactylitis or a history of dactylitis that is recorded by rheumatologist, and the radiographic evidence of the juxta-articular new bone formation in the hand or foot. Now, how to treat the case of reactive arthritis? Whenever a patient of reactive arthritis is coming to us, how are we going to treat that particular patient? According to the therapy, a coordinated therapy is directed in the skin and joints. So we are advising coordinated therapy that is directed towards the skin and joints. The patient education, physical and occupational therapy is advised. TNF modulatory agents like infliximab, NSAIDs, non-steroidal anti-inflammatory drugs, intra-articular steroidal injections, efficacy of gold standard and antimalarial, sulfasalazines, methotrexate, and leflunomide. So the treatment consists of coordinated therapy that is directed at the skin and joints, patient education, physical and occupational therapies, TNF modulatory agents, infliximab, non-steroidal anti-inflammatory drugs, intra-articular steroid injections, efficacy of the gold standard and antimalarials, sulfasalazines, methotrexate, and leflunomide. So this was all about psoriatic arthritis. Let me have a quick review of the disease once again. Psoriatic arthritis is a chronic inflammatory arthritis that affects 5 to 42% of the person with psoriasis. It refers to inflammatory musculoskeletal disease that has both autoimmune and autoinflammatory features occurring in the individual with psoriasis. It is seronegative, often involved the distal interphalangeal joints of the fingers and the spine and the sacroiliac joint. It has features similar to that of ankylosing spondylitis and reactive arthritis. The onset of psoriasis usually involves and precedes the development of a joint disease. The nail changes are seen in 90% of the patient with psoriatic arthritis. There are 6 patterns of nail involvement that are seen. One is pitting, horizontal, ridging, onycholysis, yellowish discoloration of the nails margins, dystrophic hyperkeratosis, combination of these factors. Now, pattern of joint involvement. There are 5 patterns of joint involvement that are seen in case of psoriatic arthritis. Number 1, we have asymmetrical oligoarthritis that is often involves distal interphalangeal or proximal interphalangeal joints of the hands and feet, knees, wrist, and ankles. There are sausage digits may be present, reflecting tendon sheath inflammation. There are symmetrical polyarthritis that occurs in 40% and it resembles rheumatoid arthritis, except rheumatoid factor is negative, absence of rheumatoid nodules. Next variety is the predominantly distal interphalangeal joint involvement that occurs in 15% of the individuals with a high frequency of association with psoriatic nail changes. Next is arthritis mutilans, which consists of aggressive destructive form of arthritis with severe joint deformities and bony dissolutions. There are different types of spondylitis or sacroiliitis, which includes axial involvement that is present in 20 to 40% of the patient with psoriatic arthritis. It may occur in absence of peripheral arthritis. Now, how to evaluate a case of psoriatic arthritis? In the evaluation, we have to check for the negative test of rheumatoid factor. So in the evaluation, we have to check for negative test for rheumatoid factor. Hyperproliferative anemia with elevated ESR, hyperuricemia may be present. HIV infection should be suspected in fulminant disease and inflammatory synovial fluid with biopsy without specific findings. There are various radiographic features which include erosion of the joint margin with bony ankylosis, tuft resorption of terminal phalanges with pencil and cup deformity, bone proliferation at base of distal phalanx with tapering of the proximal phalanx. There is axial skeleton with asymptomatic asymmetric sacroiliitis, asymmetrical non-marginal syndesmophytes. Now the diagnosis that is based on Casper criteria in which the patient must have inflammatory articular diseases with joint, spine, and enthesial with greater than 3 points from any of the following 5 categories. We have the evidence of a current psoriasis, a personal history of psoriasis or family history of psoriasis. There is typical psoriatic nail dystrophies with observed on current physical examination. There is negative test result from rheumatoid factor. There is either current dactylitis or a history of dactylitis that is recorded by the rheumatologist. Radiographic evidence of juxta-articular new bone formation in hands or foot. The treatment consists of coordinated therapy that is directed at the skin and joints. The patient education, physical and occupational therapy. We have TNF modulatory agent, which includes infliximab, NSAIDs, intra-articular steroid injections. We have efficacy of the gold salts and antimalarials, sulfasalazines, methotrexate, and leflunomide. So this was all about psoriatic arthritis. In the next lecture, we are going to discuss about gout. So this session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH University. I hope you have understood this session properly. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. We will be meeting with a new topic of gout in the next lecture. So this was all for today. Thank you very much. Have a good day.